Welcome to the Turd Nerds podcast. You are tuning in to the Functional Gastroenterology podcast with hosts Dr. Ilana Gurvich, Dr. Ami Kapadia, and Dr. Rebecca Sand. Let us tell you quickly who we are. I am Dr. Rebecca Sand, a naturopathic physician, acupuncturist, and educator based in Portland, Oregon. My practice specializes in the microbiome, hormone conditions, and conditions of the gut-brain axis.
I'm Dr. Ami Kapadia. I'm a medical doctor trained in family medicine and holistic medicine with a special interest in digestive health, the microbiome, and its effects on our overall health.
And I am Dr. Ilana Gurvich, a naturopathic physician and acupuncturist who is board certified in naturopathic gastroenterology. I specialize in inflammatory bowel disease, irritable bowel syndrome, and other functional GI disorders.
Okay, let's take the plunge into today's episode.
The following discussion is for educational purposes only and not intended to diagnose or treat any diseases or conditions. Please consult your doctor before incorporating any of this information into your care. The information presented on this podcast is not medical advice.
Welcome back to another episode of the Turd Nerds podcast. This is an episode that is pretty close to my heart because I feel like my goal of this episode is really to explain how we, as three individual clinicians, look at and take a GI history. Mm-hmm. I have been at this point training residents for 11 years. And when I way in like the first couple of weeks of their training, when I'm breaking down these concepts, they are looking at me like, whoa, like, why did nobody ever teach me this in school? Why is not common knowledge? Which makes me think, it's not getting taught in school and it's not common knowledge. Mm-hmm. And so I wanted to talk about how I explain it to them. And then I wanted to understand how you guys are taking a GI intake. And, I'm hoping that this is useful as a tool for clinicians when they're working with patients.
Yeah, also for patients, though, is your doctor asking you these questions? Because, a lot of people don't and they miss a lot of information. When I'm approaching an intake, and I've revised my version of this too, so I'm excited to hear both your brains on this, but I'm looking for the highest yield because we all know that there are questions that are just going to launch patients into a massive story that we actually don't need to know and can kind of waste some time. So how can we get to the biggest bang for our buck with the questions and the things that are really giving us information about their microbiome, their health history, treatments they've tried, treatments they've failed, all of that?
So let me start with my big picture view. When I'm interviewing a patient, I've never met them before. This is a brand new patient. We've never seen them before. I'm listening to their history. And my first question is, what part of the digestive system is broken? Is this upper GI, esophageal stomach? Is this small bowel disorder, or is this a large bowel disorder? Mm-hmm. It's very important to know that there are definitely patients who have issues in all three, but what I am trying to circle into is what broke first and what's causing the most problems now. Yep. And those three areas are going to directly determine how I work them up to figure out what the underlying cause is.
Makes sense.
So what do you ask?
Okay, so my first question is while I'm listening to the history, if this is an esophageal or stomach issue, I'm going to be looking for a lot of dyspepsia, a lot of reflux signs or GERD, a lot of ulcer pain, stomach pains, symptoms that happen pretty immediately after eating. Chronic discomfort, eating will generally make them worse, and their symptoms are always tied to very close into the eating window.
Right.
So that would be
if
stomach.
they've had, what standard workup they've had for, if they had an EGD, if they had a barium swallow, what kinds of things have they had evaluated so far? Have they seen a GI specialist, etc.?
Yeah.
And then the other part of that is how severe are their symptoms? A lot of patients, we get patients through our doors as integrative medicine providers in one of two ways. One way is we have the people that are like, I do not want to be in the system. I do not want to see an MD. I don't want to see a gastro. I don't believe in medicine. That's
no offense. I mean,
no, I mean, that is a portal into people who come see us.
Yeah.
And then the other portal into how people come see us is I've done all that stuff and it hasn't worked.
Yeah.
That's probably more of who I see.
That's what I see too.
Yeah.
So when I start out with a patient, I'm like, I want to get caught up on your history because I don't want to reinvent the wheel. I don't want to recommend things that you've already tried and failed. So give me the best you can from when this started, like the heavy hitting milestones. So major treatments you've tried, what happened? Imaging you've had, what happened? Diagnoses you've received, like any colonoscopies, anything to just catch me up to speed.
It's really important. I just want to expand on that. I want to see the reports.
Yeah, if we can.
I do not want the patient to tell me
Yep.
that somebody told them
It was
that-
normal.
Yep,
Yeah.
totally.
I want to, and that is a key thing, reading the reports. And like, this is reading the reports of like an endoscopy or EGD, but this is also reading the reports of a functional a
SIBO
test, a
test,
SIBO test,
for sure.
a CIFO test. Like,
Yeah.
And I think the biggest with Dr. Gurovich's talk on some of the causes of diarrhea and making sure they've ruled out microscopic colitis. This just wasn't done when they've had their colonoscopy many times. So
And I am not sure I've seen an endoscopy where they did enough biopsies to rule out celiac. Like we talked about in the episode, the number required, like people do one biopsy. And,
and just so I just want to right there, like the patient's going to be like, no, they tested me for celiac and I'm done.
Yeah.
And that, like, I think 8 out of 10 providers would be like, they tested her for celiac and she's done.
Yeah.
But if you're not reading the report and looking at the biopsies, you do not actually know that that patient was tested for celiac.
right.
Yeah.
So important to read the report, because also the standards have changed over time where, again, I don't think I even learned about microscopic colitis in medical school. So
right.
we do have great GI doctors in the area, and now they're telling the patient we should, even if you had the colonoscopy, we should recheck because you might have this. I was very happy to see that, but if they had it 10 years ago, it might not have been checked. So.
Yeah, so I think the value here is like ask about past providers and do a records request specifically for labs and imaging and any like diagnostic studies, because we need to get our eyes on those.
And that is actually one of the things that I talk to patients about. I'll often do a 15-minute free consult with them just to see if they're a good fit for me. And I'll be like, what I need from you is I need you to get all of your reports.
Totally.
Let's start even before the visit. Let's start so I can look it over while we're together and I can explain to you what sentence was finished, where was this paragraph closed, and what is a ... that was never followed up on. And that's where we should be starting, not like where you are today.
Yeah. I recently had a patient who lots of significant bowel issues and had a colonoscopy recently because of a lot of blood in stool, and called the gastro's office to confirm like the results because she never got them and there was no follow-up. And the person on the phone just said, yep, it was completely normal, nothing. Meanwhile, this person's bleeding with every bowel movement. And I got the report, and it actually didn't say anything but diverticula, in the intestines, but like no mention of hemorrhoids, nothing in there. But it wasn't completely benign. Like there were outpouchings and whatnot, but that was completely normal to the viewer, reading that report. So,
and another thing I've seen frequently is patients with upper abdominal or right upper quadrant pain, and they say they've been ruled out for gallbladder disease. There's been an ultrasound, but they didn't order a HIDA scan. Do you guys
Right.
see that frequently? That it's just that next step wasn't taken and it's just been
Yes.
stopped? Okay.
Yes. And that's why we need to be, like, if we're looking at it with our integrative eyes, with our naturopathic eyes, with our functional medicine eyes.
Or just a regular good looking at.
just blow bar, doing our due diligence.
Like do it, because I mean we always learned if the ultrasound's normal but they're having that kind of pain, you need to get it's actually a functional test, right? A HIDA scan to see if the gallbladder is functioning properly,
Right.
even if there's not stones.
So basically the intake, we ask our patients about this to get an idea of what's out there.
Right.
We're not taking their word at face value, even though we want to believe our patients and believe their symptoms, what their assessment was, because they probably were not told the truth in some cases.
Or it got lost in translation,
Yep.
which is more often what
Exactly.
happens.
Yeah, I don't
Exactly.
think it was. I think it usually is just probably a time issue and a communication
For
issue,
sure.
and the number of patients that these
And-
poor people are required to see.
And we have different standards on things.
we might be looking for different things
exactly,
too. So.
Exactly. I've seen a number of people order functional stool lab testing and say it was completely normal. And I get it in my hands and I'm like, whoa.
Yeah. I'm
I
like,
got some work to do.
there's this one patient in particular who was seeing me, and it was a virtual, it was COVID times, and we started out virtually and we continued virtually, but she had some kind of stool test, and I was like, okay, can I see it? And I was like, oh, you had Dientamoeba fragilis and Blastocystis homini. Those are two protozoa. And she was like, oh yeah, the doctor just told me it was fine. And it might be fine. They might be protozoa, but
Yeah.
for some people they're pathologic,
Uh-huh.
and her symptoms sure did match what a protozoal overgrowth would look
And
like.
with treatment, they get better.
And the opposite, there's one or two particular functional stool tests that I feel like overdiagnose things and scare the patients, get scared into thinking they have all these problems, and then I take their history and I'm like, I think you're okay, and maybe we created more problems by giving you this. So I think, again,
Yeah.
just looking at it ourselves and going it over with the patient.
That's a
'cause
really good point.
It may not, they may think they have all kinds of things going on, and those tests can change from day to day, like inflammatory markers that they're checking in the
Exactly.
stool and these kinds of things.
Yeah,
so.
it gives us a door to educate our patients on what this means, because odds are when they come to us, people didn't adequately explain, this is what this test is looking for. These are the, like, referencing back to our secretory IgA episode, this is what this means, this is what this doesn't mean.
Right.
This is what it could potentially mean.
Yep.
And so the other side of that, the first side is, did you look at their history? Did you collect all their data? The second side of this is their primary complaint an upper GI, esophageal, or stomach issue?
Yep.
What is the testing that we want to do that only focuses on that upper GI stomach pathology, right? You don't need to do the 1,000 tests like from the bottom to the top.
Yep.
You need to prioritize this symptom picture is really upper GI. Let's prioritize testing and working up and cleaning up this upper system to see if that corrects it down the line. So that would be stomach esophageal, right? The next thing I'm looking for is it a small bowel disorder?
I feel like this is the trickiest, but also my favorite.
Yes, I would agree with that, actually.
You have a favorite GI? Okay.
Yeah, my favorite organ is the small intestine.
I think I'm more partial to the large intestine, but I support you.
All right, well, that's why we're a team.
So the small intestine, what we're looking for there, the most common symptom that I see in the small intestine is bloating.
Yep, absolutely.
So, the stomach, when you have gas in the stomach, you belch, it goes on up. When you have gas in the large intestine, you fart, it goes on down.
Yep.
When you have gas in the small intestine, there's a valve on the top and there's a valve on the bottom.
Gets stuck.
You bloat.
Yep, totally.
And so then I'm like, okay, is this a small bowel issue? Is the small bowel the thing that's looking like it's not working? Pain after eating, but not directly after eating, within, an hour or so, lots of bloating, lots of dyspepsia, like feel unsettled stomach, or even like food stagnation is what we call it in Chinese medicine.
Yep.
Those are all small bowel disorders.
Yep.
If I'm going to see that, I want to see what kind of imaging they had, what kind of testing, did they have a proper celiac test?
Yep.
Did they, and then the other thing is I want to see, is there something that's showing me a fungal overgrowth, a bacterial overgrowth within the small intestine?
Yeah.
That would be a SIBO test. My preference is lactulose. I'm sure people will argue that glucose has value.
Boy, will they. Yep.
Fungal overgrowth, stuff like that. And then on top of that, what I will say, which is shocking to me, is how many providers, both conventional and integrative, do not know how to properly read like a SIBO test. Like that happens all of the time.
I know.
Still.
Yep. That's why I request them.
A really good episode would be then next time going into the workup of the different three sections that you're dividing this up in. But go ahead.
That's a really good point.
So then that's when I want to, like I had a patient just come in on Friday and she came in with 6 SIBO tests. And she was like, well, I mean, they went they went normal and then now they're abnormal. And I was like, looking at them, I'm like 3 years deep. And I was like, they were never normal, but also you've had 7 of them and you've treated them again and again and again.
Yeah.
I don't think SIBO's your problem.
That's it. Like barking up the wrong tree.
Yep.
Right.
Yeah.
Unless it never shifted and she wasn't treated appropriately. But yeah.
In my experience, when it doesn't shift, that actually has more to do with the fact that there's something else
Right.
going on that's preventing it from shifting.
Yeah,
Right.
I tell my patients, I have no doubt you have SIBO. I definitely think you have SIBO. I just don't think it's your biggest problem.
Right.
But it's good to look at those results. All right, when you're asking to order things like functional lab testing, are you going all the way back? Or are you saying in the last year, last 5 years?
I want to say at least, if I can get 3 to 5 years,
Okay.
I'm curious.
That's what I asked for functional tests within the last 5 years,
Yep.
regular routine
work.
lab work in the last year.
Yep.
If they've had procedures, then even further back, like endoscopy, colonoscopy.
Yeah, that's exactly what I do. Yeah, totally.
Yeah, and I would
it
go as far
depends
back
on-
as I can go for those,
Right.
for the
Yeah.
procedures.
Yeah.
And, inflammatory bowel disease is one of my favorite things to treat and one of my specialties. It's really important for me to see where a patient got resected. Like that's a thing that's going to change their anatomy for the rest of their lives.
Totally.
I need to see where they've been resected.
Yeah. And scar tissue. I mean, speaking of SIBO, yeah, totally. Okay, so and then like what would help you think of lower bowel type
So
stuff?
lower bowel, they don't have the bloating.
Yep.
It's like they're having problems with defecation.
I will say unless they're constipated. And I ask patients where their bloating is, because if it's in that like right lower quadrant, like by the appendix, it's probably backed up stool. And if we get their bowels moving, it goes like that can
That is a super true point.
yeah, the tube is plugged. you
Yep.
know?
And I mean, this is a conversation where there is no black or white.
Mm-hmm.
There is like, when you're differentiating between the large and the small intestine,
Mm-hmm.
it is a bunch of gray. I usually will prioritize what seems like the biggest problem
Yeah.
and treat it
Yeah.
and then see if I'm right.
I think of it as a tube.
Uh-huh.
You know, the digestive tract really is a tube, and where
it
is the
getting
problem,
clogged
which is
or-
kind of what you're talking about.
Yeah.
But one of my lately, I've been doing this approach of just can we get the tube regulated from a motility standpoint, and then reassess what the problem is.
So can you, you just use a keyword from a motility standpoint. Can
Yeah.
you explain that? Because that's a big thing.
yeah, I mean, so it's a tube that needs to move.
I hear that.
We are just a tube. We're just worms. Tube that needs to move. If something stopped for some reason, whether it's adhesions in the small intestine, whether it's stool in the large intestine, whatever it is.
Whether it's
Or
a
an actual
dysfunction,
dysmotility.
which
Yep.
a dysfunctional nervous system
Yep.
that's not moving the
Yep.
tube.
Yep. Serotonin deficiencies, like medication side effects. I mean, the list goes on with that. But if I can get people regulated with, let's say, prokinetics, laxatives, get their stool slowing down, you know, if they're having urgent diarrhea, things like that, and then reassess. Did that solve the bloating? Did that solve the nausea? Like, did it solve all your problems? Or, okay, now you're pooping regularly, but you still have X, Y, and Z. That helps me decide
right.
where in the body the root of the problem might be.
Right, because I've had patients where the constipation improves, but they're still having significant bloating.
Totally.
Then it becomes more
But
confusing.
some people, we get their bowels out, give them a week,
And they get better.
and we
Yeah.
never see them again because
That's
they
a
get
much
to go live
better
their
outcome.
life.
So
Yeah.
I had this patient come in.
Wasn't my story, we'll say.
But if we
but-
can pick it, that's a better way
I had
to
a
go.
patient come in, young woman with a young child at home, toddler, and she came in looking easily 7 or 8 months pregnant.
Yeah.
Like she came in so distended. I literally, I didn't say anything, but I just assumed she was pregnant.
Yeah.
And we were talking, and she was like, well, yeah, I think, I saw a gastro, and he told me to use Miralax, and I used it for a week, and everything felt better. But then I stopped using it because I don't want to be on a drug, because, there's this bias of I don't want to take anything. I don't want to be on a drug. And then everything came back, and now I'm like super distended, and I just don't poop. And I was like, can we just put you on the Miralax
Right.
protocol?
I mean,
like, it's cheap.
yeah.
Do I love polyethanol glycol? No, but did it work for her?
It's probably better than not having bowel movements.
definitely better than not
least
having
you're
bowel
getting
Definitely
movements.
things
better,
out.
and it's
Yeah.
not our only tool.
Yeah.
Right, but here's the
At
thing.
least for temporary.
It worked.
It totally works.
And on her follow-up, which was like, I think I saw her 2 weeks later, she did not look pregnant.
I will say the vast majority of my people coming in for diarrhea or constipation, but especially constipation, like we'll do some blood work if they haven't had that done, but I'm holding off on a lot of the expensive functional lab testing until I get their bowels moving. And I'm like, try this like easy protocol, whether it's like osmotics, bulk forming, whatever, cheap, easy, to tolerance, and then follow up.
And as we learned, fluid, fiber, and movement
Exactly.
might all three be missing.
100%.
Well, yes.
And sometimes
just-
the bowels need to be jump started. Like we just got to get it moving,
Right, get
and
things
then
moving.
the body takes over.
Yeah.
I also want to say though, with bloating or any of these other symptoms, it helps me elucidate if there's a hormonal component.
Because there often is, thanks to the estrobolone.
Yeah, big
Yep.
time. So
Yep.
is that bloating like specifically around their cycle, but we didn't know because there's a little bloating with the constipation? Like it just
And
gives us more
just a
data.
reminder, women are significantly more likely to be either
man.
be constipated
We
or
could
B,
unpack that.
report to the doctor about their constipation.
Mm-hmm.
Like, but it doesn't matter. Women have cycling women in their fertile years have hormones that definitively affect their bowel movements.
Mm-hmm.
And honestly, if you ask, like any female that asks 75% of her friends, they will tell you they either have constipation or diarrhea prior to their period
And
or
for sure
during.
bloating. Yeah, and if you're not pooping right, whether it's too fast or too slow, it's going to throw off your hormones. And,
Well, because with the constipation, with estrogen detox, right? So
Yep.
that's going to get...
yep, got to unplug the bathtub.
So
Get it
then,
draining.
so now we're like, okay, small bowel, we work that up. We're going to focus on that. That seems like the primary issue. That can also be a constipation factor
Yep.
within that. So just because the large intestine isn't working right doesn't mean it's the large intestine. It could also be the small intestine making the large intestine not work right. But you unpack that, and then if it's not that, then you start to get the wheels going. But then you also do the functional or the regular GI workup.
Yeah.
You know, like if it's seeming like it might be an IBD like picture, make really push for the scope.
Totally. Yep.
Can I just throw in, you know how we like to get obsessed with like macro, micronutrients, other. So I'm recently obsessed with fiber. We visited some relatives who are doing, I'm not saying everyone should do this, but they're doing, you know, fully plant-based diet for cardiac reasons and following some of the work of people like Michael Greger and Essenstein, all these different doctors who really advocate for plant-based diets. And so I've become obsessed with fiber recently, and I feel like the morning oatmeal has gotten a bad rap.
Has it? Because it's one of my favorites.
Oh, I've never seen you. I've seen you eat oatmeal once.
No. Not for me. Actually,
Okay.
my body does okay with oatmeal, but not nearly as good as it does
But
with
for
eggs.
fiber, so here's what I figured out. You don't want to eat just like plain oatmeal, but I can now get 12 to 15 grams of fiber in with breakfast and not have any blood sugar instability by doing oatmeal plus berry blend, blackberries, etc. You can get 7 grams of fiber in a serving of berries. There's 5 to 6 grams of fiber in the oatmeal. Flaxseed, crush up some nuts if you have some dental challenges like me, or, you know, eat them whole. And I've got like literally 12 to 15 grams of fiber with
Do you
breakfast.
know what you're?
Bravo,
Do you know
Amy,
what?
bravo.
Whoa!
I've been so excited, and it tastes amazing.
I'm
Alana's
gonna
one-up
one up you. You need to add chia in there.
Yeah.
I have some dental challenge. The chia seed gets
Her
stuck,
dental
okay?
challenge is she has braces.
And
That's her dental challenge.
It's more than that, but we don't need to go into the details. So I left out the chia for
We'll
now, but
future plan
I
chia
agree.
for you.
But she so what we're doing at my house, because it's the easiest breakfast ever, is overnight oats.
Right. I like it hot.
Oh, I
Same.
you could do
overnight
the
oats
overnight.
room. So my if I'm
Yeah.
gonna do an overnight oat, which I probably can get away with like 1, maybe 2 times a week,
Right.
but I don't.
And
It's not great for
right.
my body. But I'll do like oats and then the chia, which gets soft, so it's not like sticky anymore into your
Right.
teeth.
Okay.
And then
Maybe.
the fruits that you're doing, I'll also add protein because for me, I need protein for my blood sugar.
The
Peanut butter and
the nuts and the oats have protein.
I'll do peanut
And the
butter
nuts.
and yogurt
Okay.
and nuts.
Ooh, I like the yogurt.
Yeah, and the peanut butter is also really
Oh, I
creamy
love
in this
peanut
other way.
butter.
Totally.
Who doesn't love peanut butter?
Yeah.
Anybody who has aflatoxin sensitivity?
Yeah. Our moldies out there.
Especially- yeah.
Yeah.
Okay.
I can't believe
Moldy
Dr.
buddies.
Kapadia is like,
Yeah.
who doesn't
I
like
love
peanut butter?
Yeah, I
I
was
love
expecting
peanut
some
butter.
backlash on that one over there, but okay. So, okay.
Okay, sorry.
Anything
This
left
is
on that? Yeah,
fiber.
a bit of a tangent. I love talking about
Detour,
breakfast.
detour.
Anything else on the large intestine?
I feel like that's the question is that where you're supposed to start? Is that the organ that's broken? And again, the one thing that we didn't talk about is peristalsis from a different neurological standpoint because, hormones can make the GI go funny, but also nerves can make the GI go
And
funny.
actual neurologic disorders, MS, Parkinson's, etc., or stress.
Yeah.
or both.
Also, small fiber neuropathies will have a great impact on the GI tract, and that is one that we are kind of blind to.
Yep.
And then also, can we really talk about the GI without talking about the histamine picture?
Oh,
and
yeah.
like, so when you're taking the history, you're like, is there other histamine stuff here? Like, am I thinking about this as one of the core causes of the underlying cause?
So maybe we can break this into like HPI type questions. Like how many bowel movements a day are you having? Any blood, mucus, undigested food, any oil in your stool, that kind of stuff. And then the review of systems, that's going to be like, do you have allergies?
So I have learned through years of experience that I no longer say how many bowel movements a day. I now say how many bowel movements a day or a week.
Yep, totally.
Because somebody will answer
You don't
one or
just
two.
say, are you constipated and move on?
Okay, so constipation.
That was a trap. That was a trap. I say, how often are you having a bowel movement?
Yeah, and then I'll show them the Bristol stool chart. I happen to have a Bristol stool chart right now that matches the stool with a food.
Oh,
I feel like I saw
the
you.
best.
Is
Did
banana
someone
number
give you
4?
this?
No sausage.
Oh, gross.
I found it online and then I
Gross.
downloaded it because it's so good. So it's like
Whenever I see one of Dr. Gurovich's patients, they know the Bristol
I
stool
know,
chart better
it's-
than me.
I know. I'm like, wait, what's so
Yeah, I
weird?
have to look up which one it is. Still.
so my diagram has rabbit droppings is number 1. Bunch
is
of
that?
grapes is number 2.
Oh, rabbit dropping.
Rabbit droppings because there's no food like around. I guess grapes would be number 1.
Hazelnuts?
A bunch of grapes is number 2.
is a
Corn on the cob.
Terrible tangent.
Corn on the cob is number 3.
Oh, yeah,
Sausage is 4. Chicken nuggets is 5.
And you want
Wait, porridge
a
is 6,
sausage.
gravy is 7.
Okay.
And you want a 3 or a 4. That would be ideal.
You know, the porridge and gravy, that's good. Because I
Yes.
think people get confused by the picture.
Yes. You know what else? I'm in the process of my big conference that I put on every year is actually next week.
Yeah.
And we're getting all of these like emojis. And I was like talking to my conference planner and I was like, why are all of the emojis a Bristol 6 and not a Bristol 4?
Yeah.
Like they're all a Bristol 6. That's not a
Really?
healthy stool. Yeah. They're all like little,
Oh, you're right.
yeah.
Even
Totally.
ours.
The little poop pile.
Yeah.
Yeah.
Yes. Even, what Dr. Cavati was saying is we have a little group chat and it's our logo, which is a Bristol 6. Like, that's not
But
a healthy poop.
also the Turd Nerds logo. But we do specialize in, things gone wrong.
Yeah,
So
it's true.
They're
That's
not-
a good point.
Patients
That's a
usually
good
don't
point.
come in
It's
with
just
the
true
4.
advertising.
Yeah, people
Yeah.
don't come in with the 4.
No one would be listening.
Yeah.
Those people are just out. I don't know.
And
what
that's
they're
why
doing
we
with all their
still
time.
can make this podcast for free.
Okay, so I have a list of questions too that I'm sure we all share. Maybe I'll just start listing them off and we can discuss. History of food poisoning. Mm-hmm. I ask, do you know what the food was?
Oh, why? What are you thinking there?
Because like some people, it's I ate that like raw oyster versus Thai
Parasite?
food.
Bacteria.
Totally.
Got it. Cool.
Yeah.
Yes.
And a lot. I mean, you'd be surprised at how many people are like, "Oh yeah, boy, do I know what it was."
That
or
is-
like.
I don't ask that question, but I don't know how I
But if
don't
it's
ask that
not
question.
acute,
Yes,
Yeah,
but
but
it's
it
parasite versus
Tells me
bacteria.
what
I
potentially
just
could have
assume
seeded
they've all
there.
got it all. Okay, go ahead.
Yeah. And recently a lot of it, because a lot of people were going to Mexico during COVID.
Oh, that was a problem.
It was
no.
people
I mean,
could very
actually, you should go if you want.
totally. I know, and then it brings
you
us a lot of
Take
business.
Dr. Gervich's travel protocol,
For sure,
and then you'll be
for
good.
Sure. Yeah.
Yeah.
A lot of people can even differentiate, like, it was the cilantro on that taco.
Bacteria.
They
I
know
do
it
only
wasn't
buy
the meat.
cilantro that's grown in the U.S.
Yeah, we had that shot. I made a mental note to do that too, and then I
Okay,
completely
wait.
forgot.
I did not. I was not part
Oh,
of this
my
trip.
husband he goes crazy. He's like, I can't keep up with your
I
stuff.
totally
You buy
thought
it
we did it
yourself.
on this podcast.
No, I don't remember.
Yeah,
You
no.
only
Dr.
buy-
Chung told. Yeah.
You only buy cilantro grown in America.
Yep. It could be watered with sewage water and other.
Yeah, but don't you
processes.
rinse it before you use it?
I don't know that it gets it all out, and I don't cook it.
Back to secretory
topping.
IGA. you're missing out. You're missing out. Okay, another one. History. Oh, do we want to talk about why we ask about food poisoning?
No. Yes.
I mean, we'll just
Precursor
touch
to
on it.
IBS, motility issues.
Yeah.
Post-infectious IBS. Yep.
Yeah. Okay. History of travelers' diarrhea.
Yes.
I will also ask where and what symptoms, because people do not always categorize traveler's diarrhea as the same thing. They'll be like, oh yeah, I had that in, Costa Rica. And then when I ask further, they just vomited the entire time.
So that's a small bowel. That's
Exactly.
not looking at large bowel. Yeah, these are
Their
genius.
bowels were actually okay. So I do a little bit deeper digging. What were your symptoms and where were you?
Okay, I just want to say
And how were you treated?
this is why a good history is the most important tool we have as clinicians.
And I mean,
right
the
here.
vomiting is probably food poisoning that they'll self-resolve, right?
Right.
So,
Yeah. Versus, yeah.
But
Lots of
also, you're
things.
thinking more small bowel as opposed to large bowel.
And I'm
Right.
also wanting to know, like, was it the water you had? Was it a fresh fruit you had? Was it something cooked? Was it seafood? Was it meat? Okay. History of parasite or protozoa known? Because a lot of people will be like, I don't know. And if you did have that, how was it treated?
And did it help?
Did it help? Have you been sick ever
right.
since?
Have you been treated with 20 different pharmaceuticals and none of them
Yep.
have worked and we're still treating the same thing over and over?
Totally.
And it's probably not that.
And or did they
Yes.
absolutely bomb your gut with drugs? Because
Right.
I need to know that too. Which,
And then we're thinking more fungus as a possibility or histamine
yeah.
issues.
Yeah, did we set you up for just a raging biofilm, with that treatment? I really like to ask about history of abdominal or pelvic surgeries.
Oh, of course,
Yeah.
for adhesions.
Adhesions. And in that vein, I follow up with, do you have all your organs? Because you'd be surprised at how many people are like, no, I've never had any. Oh, but yeah, I did have hernia surgery when I was a baby. Or, oh yeah, I got my appendix out when I was 9. But they've blocked that out. Or I ask about C-sections because some people may not associate that because
With adhesions.
with surgeries even.
Yeah.
It just was a different thing in their head. So I specifically asked, do you have all your organs, any organs removed? And then again in that vein, endometriosis, because a great way to get internal scarring is an inflammatory disorder that can spread throughout the peritoneum.
Yes, that it was a very fast way to get internal scarring. I would agree.
Yeah, and it does. It can land on the bowels. It
So
can cause
I-
things pulling.
So a quick patient story, because I do feel like it helps bring it in.
Yep.
I had a patient who came in to see me, really, really sweet young lady. And on the first visit, she's telling me about all of her SIBO-like symptoms. And we start, taking a menstrual history, which is vital for any female.
Yep.
And I'm listening to her menstrual symptoms and I'm like, oh, that's bad.
Yeah.
That's not a normal menstrual
One
cycle.
in
What was
10.
her history?
1 in 10 with endometriosis.
So intense abdominal pain. She needs to either take very high dose NSAIDs or she needs to take
Opioids.
Yep. She hurts. She gets terribly constipated. She's chronically distended. It's like she basically cannot function around her
So
menstruation.
you think she probably has
bleeding.
endometriosis?
So let me finish the story.
I can never wait till the end.
She's bleeding in her abdomen.
Spoiler alert,
I already
Dr.
know.
Kavadia. Okay, so from the first visit, she'd never seen a gastro. She worked with her primary a little bit, but really nothing very much. So, this is like one of those, I'm kind of interested in seeing any ND patients. Not everybody else has failed me patients. And so I'm listening to her, and from the very first visit, I'm like, okay, it does sound like SIBO. You do have all the bloating. You do have the bowel changes. I'm going to guess it's a methane positive, but we'll see. But I'm also going to say this is not a normal period. So, there is this marriage that happens between IBS and endo that we see often. Because,
or IBD and endo.
or
right?
IBD and endo, but I see it
SIBO
much
and
more with SIBO and endo. Like I think that unfortunately it's a marriage made in
Across
hell.
the board.
It's
Yeah,
it's a very abusive relationship.
I
So
shouldn't laugh, but that's a very good description.
so we start treating, right? We go through, she wants to do herbs first, so we go through a round of herbs. She gets into symptomatic improvement for a little bit. Within 2 cycles, she's back. We retest. There's been I was right. It was very methane positive. I think she started in her 50s or 60s with methane, a peak of 50 or 60 within the first 90 minutes. And so then we circle back around. We treat with antibiotics. She gets less traction, but no improvement. Every cycle, she has this awareness that she never had before, that periods are not supposed to be that painful.
Yeah.
Right?
Right.
All of a sudden, this awareness.
Because she had improvement with the treatment cycles.
Yep. And with the other thing that I did right away is I have a great GYN that I send people to who I think is probably the best endo GYN in Portland. And so I was like, let's get on her schedule. It's going to be a wait. So we'll do our things. You can cancel, whatever, but let's start moving that process.
Yep.
So I think we're like 5 months, 6 months in, really from a big picture view, she has not gotten better. She finally she works with a GYN a little bit and the GYN's like, I'm not ready to call it endo. Let's work you up for primary dysmenorrhea and kind of rule stuff out. And by the 6th month, she's just debilitated.
Did she get on birth control?
They tried to put her on birth control.
Didn't help?
So what happened is I ended up referring her over to an endosurgeon group, which I
Yeah.
really like.
Yeah.
I like the endosurgeon groups that does the excisions, not just the ablations.
Yep, totally.
And she went in and he staged her at stage 4A endometriosis.
Totally.
She had endometriomas adhesed to her rectum.
Yep.
Which is why they were all over her peritoneal cavity. They were all over her intestine,
Yep.
which is why she was having those symptoms.
That's it. It's so common. And then they bleed and they're inflamed. I mean, so many people are not getting the care that they need for exactly what you just said.
Yeah.
I did have a patient with inflammatory bowel disease. I think it's ulcerative colitis and endometriosis, and she had what sounds like she's a very motivated patient, super nice. She had a team of surgeons where the colorectal surgeon and that's I think probably that same group.
Endo group.
Yeah, they worked together on her surgery because it was so complicated, but she's doing much better now.
And I will say, like, getting that excised, getting that inflammatory tissue out is very important for certain cases. But the surgery itself is going to cause adhesions too.
Right.
Even a laparoscopy, because it's minimally invasive from the outside, but inside it can cause scarring, even if you're just looking around.
So the reason why I wanted to bring up this case in particular was because sometimes you're taking a GI history,
Right, and there's
but the problem is not the GI.
Oh, man. Right.
The
Totally.
symptoms are the GI, but the problem is something else,
Yep.
which is the other thing you're looking for in your GI history.
Yeah, and this
Right.
is why I love the crossover
Yeah.
with hormones and the gut, because it's so common. And
Yes.
I'm like, yes, it's affecting your bowels. Yes, it's making you bloated. This is not your problem.
Yes.
It's not the root of your problem. So why do we care about asking about adhesions? Why does that matter?
obstructions, motility.
Motility for sure. Yep.
Adhesions means that the small bowel and the large bowel can't move freely because
Yep.
they're adhesed, which obviously is going to cause symptoms.
Yeah, and I tell my patients that if things are tugging, it allows opportunities for the intestine, specifically the small intestine, to pool. And when contents of the digestive tract pool, we grow things. So I do see it as like a risk for recurrent SIBO, recurrent infections, things like that. We don't want anything pooling in there. Okay, other things. I ask people, this is going to be a no-brainer, but frequency of antibiotics, I chunk it out into like, how often have you needed them in the last 5 years, in adulthood, and then in childhood. And I give examples like for acne, for like people take them before intercourse, prophylactically, for dental procedures, recurrent sinus infections, like
Usually recurrent ear infections or recurrent strep throat as a
totally
kid.
pneumonia, bronchitis.
I do think that's one of the reasons I developed Crohn's disease. I had medical doctor parents.
Yeah.
I took at least 2 rounds of antibiotics every summer. I
Right,
had ear
right.
infections. I was
did
swimming in
the
a
same.
lake nonstop.
Yep. I know my gut doesn't work.
Yep.
It works fine now.
My gut's not bad.
Yeah, well, whatever. Wait, that's a
Yeah. I mean, I'm going to say my gut's not bad because thank God for magnesium.
yeah.
Yeah, magnesium is like,
better than I was.
when it stops working, I'm going to be bummed.
I'm
Try my
precalibrate.
oatmeal recipe. It'll be good.
I'm going to take your oatmeal recipe and top it with chia.
So I also ask about probiotics.
Uh-huh.
And I specifically want to know, did people feel worse on probiotics?
Oh, what are you thinking there?
Small bowel.
Keep
Because
talking.
you're overloading the small intestine with, it's just got too much already. It can't, if you're taking good probiotics and or like a lot of them, it's too much. And people will get SIBO-like symptoms when they take probiotics if they have SIBO. Mm-hmm. So you're just adding too much in. Do you ask that at all?
Always.
Either of you? Okay.
And my thought process with probiotics, I feel like ever since the probiotic research has gone to species specific
Yeah,
from
totally.
from like groups of diverse strains,
yeah.
I just don't see as much efficacy as I used to.
Yeah.
And so I've entered a fermented food train.
Yeah. Yeah,
So-
with some exceptions, but the data on probiotics looks very enticing. And
Yes.
clinically, we've talked about this.
Clinically, it's a want.
There are some good ones out there, and sometimes we use it. But, yeah.
Yeah.
And then dental history.
Talk about that.
Yeah, so I'm asking about like dental procedure history, what kind of dentist you were working with, what they found, have you received dental care, and then like their own perception, have you had chronic tooth pain you just haven't gotten care for, or things like that.
Because
It can seed the gut, seed the microbiome. And then the last thing, anything else about dental?
I mean, from my perspective, just from a neurotherapy injection perspective, also it's a scar, and so it can shut down the nervous system because it's a scar that blocks communication from the peripheral
And
and central
we
nervous
start
system.
digestion in the mouth. If that's not working, like we have barriers there, we're breaking stuff down, like we need that working. The last one I'll say here is since this podcast, ask a whole lot more about allergies. And that
Yes.
I've gotten a lot of improvement in people that were just not getting better because that was a component. So tell me about allergies and what you're doing to manage them.
That is my favorite part about specializing the GI.
Yeah.
There are so many layers that you can dive into that help you like almost tease apart what's happening.
Yeah.
But that has to be the core of every patient visit, especially a new patient visit. Like what happens oftentimes is they walk in to see either a naturopath or a functional medicine doctor and there's no focus, right? And so they end up walking out with, probably a $400 to $800 bill just for the visit, and then probably another $2,000 worth of testing.
Totally.
And that for me is a waste of their finances, but B, also a waste of time because
Everyone's time.
Because when you get all that information back, if you don't know how to prioritize it,
Yeah.
then you're like, what's the point?
Yeah.
Well, and I think even for non-specialists doing family medicine or general primary care, we just know that so many of our issues stem from gut dysfunction.
Absolutely.
From, traditional healing systems to current research on the microbiome. And so even if you're not a specialist, it's still often a good place to start, regardless of what the patient has, rather than chasing after all these other things.
Yeah, and I think there's a growing awareness of that. Like people are coming in. I even have patients coming in where their gut's fine, but they're worried about it because they've heard it's the basis of everything and they want to get it fixed up. And I'm like,
Well, it's also a good starting point for nutrition and movement and all the
nutrient
things.
absorption. Like,
Right.
Are you getting your drugs in,
Right.
your nutrients in your food,
Yeah.
Yeah, it matters. So good to ask these questions.
Okay, so I'll give you my take home, and then my take home really is start from the top, work your way down, really choose your testing, prioritize your testing based on what's the loudest, scream the loudest, and has the most dysfunction. Don't start with everything. Choose your battles, and also don't believe a patient's history. Look at the reports.
Yeah, get a records request.
Yeah, that's my take home.
I agree.
I would just say I try to cast a wide net, especially. I mean, new patient visits, like we've talked about, are a lot more work. but the more info you get a clearer idea on what you're treating and what you're aiming for, so you're not wasting people's time and money shooting in the dark.
I think the history is really important just for even looking back on, because even if you're going to, I generally start with more broad-based strategies with nutrition and lifestyle.
Yeah.
And I order some labs, but not a ton of labs initially, because I just don't want to over test and over treat. But it's good to have that initial history, because then if you're not making progress, you kind of have a menu of, okay, that's what I tell patients. The first visit, we make a menu of here's where we're going to start. Here's future thoughts for if we're not making progress. But I don't lump all of that together, because I know I can, from that first history, we can always look back and tease apart, okay, what do we do next if the basics didn't work?
Yeah.
The other thing about that first history is you will have patients where you've made like a crap ton of progress, but they
forget.
They are in their own lives,
That's
their own
it.
their own bodies.
That's it.
And so I like to pull it up and say, okay, on the first visit, you said X, Y, and Z. Are these things true anymore?
Yeah.
And then it's like my gentle, I told you so, without saying, I told you so.
Yeah, and some people just orient to being kind of like fused with their condition, and even though it's better, they're still really stuck in that mindset.
Yeah.
So, yeah, I think that's really important. And then the only other thing I would say about this is there are a lot of comorbidities with gut stuff.
Yeah.
Like, we know this. So if you're doing a thorough intake and you realize their anxiety around their constipation, maybe even more severe than their constipation, don't forget that.
Yeah.
You're going to get way better traction and probably a lot better buy-in on whatever you want to do, because you get them feeling better.
Good point.
So,
Good point.
great episode.
Thanks, everybody.
for tuning in.
Thank you.
Thanks for joining us today. Stay tuned. We release episodes every 2 weeks.
If you like this episode, please subscribe and don't forget to rate and review us to help spread the Turd Nerd word.